So thank you to the HSCC team for asking me to be here today. And it's a pleasure always to work together with Susie, with whom we are collaborating very much and clinically and internationally. So thank you very much. And we look forward to your questions. So Susie already has talked a bit about ovarian cancer from the medical oncology side. I'm going to show you some new insights into the surgical approaches for ovarian cancer. First of all, some facts so that you understand why surgery is so important. Ovarian cancer is a disease that is it's rare, much more rare than, for example, breast cancer, which affects 1 in 8 women. Ovarian cancer will affect 1 in 56 women. So it's much more difficult to do large-scale clinical trials, to get expertise, to get exposure. And that is why international networking and collaborations are massively important. So what is the very tricky part in this disease? The tricky part is that because of the unspecificity of symptoms, more than 70% of patients will already present at a late stage. Why is that? The problem is that the main symptoms initially for ovarian cancer are very common to IBS, so irritable bowel syndrome, or perimenopause or food intolerance. So the majority of the women will go to their GPs and they will go back and forth for months with abdominal bloating, with some pain, with some bowel irregularities. They will be told that it's all IBS, that it's all menopause. So that unfortunately we know from studies that the average time till we have a diagnosis is around 6 months. So when the women come to us, the disease is already outside of the ovaries, outside of the fallopian tubes, outside of the pelvis, and the surgeries are extensive. Now, I know we have many non-doctors among us. Still, this is a very important, I think it's the only surgical picture I will show. This is, I think, one of the most important slides for you to understand how ovarian cancer disseminates and how this reflects on surgery. Ovarian cancer, the most common type, the high-grade serous ovarian cancer, is not really coming from the ovary. It comes from the fallopian tubes. So over the course of years, of decades even, nobody really knows how long, there are tiny small cells, precancerous cells, at the end of the fallopian tubes. And they sit there. However, because the fallopian tube is open in our tummy to get the egg, to collect the egg, it can do exactly the opposite movement to shed, like a trumpet shedding air into an entire room, and sheds all these little cells into the entire peritoneal cavity. That is why many women with so-called ovarian cancer, which at the end is a fallopian tube cancer, they have pictures like that with completely normal ovaries, but little seedings like snowflakes, as if it snows in somebody's abdomen on the entire skin of the tummy. So this, of course, can be very tricky. Why? Because when patients go with symptoms to the GP, they might have an ultrasound, and the ultrasound may show normal ovaries, so that the diagnosis gets delayed even more. For that reason, many women, they will come to us with this picture with many, many seedings, many sand cores or sugar flakes on the entire abdomen. And the question is, what do we do? So surgery for ovarian cancer has evolved massively in the last decades. Many decades ago, we would just remove the ovaries and give chemotherapy to the rest, which we know is not effective. We now have learned that by removing all these little snowflakes, all these little sand cones, the patients will do better and our women will live longer, and we can even increase cure rates and survival. For that reason, we as surgeons and gynaecology community have started to increase the radicality of our surgeries and started to try to remove all these little snowflakes on the various organs by removing bowel, by removing spleen, by removing lymph nodes, in order to be able to have a clean abdomen at the end without all these little dots that I showed you before. And does this bring anything? Yes, it does. We know from many, many studies that when you operate somebody without visible residual disease, the patients will live longer. You see here the pink curve, patients do much better than if they have residual disease. And you see here everywhere, tumor-free, tumor-free, tumor-free. It's much better than if somebody leaves residual disease inside. So we as gynaecology community, we as professionals in Imperial, in the Marsden, in all big gynae cancer centers in the UK, we have started to expand the limitations of operability and also started to expand the framework of our research in order to increase survival for our patients. So we have seen from many studies that in order to get a patient tumor-free, we will need more than half of the patients to have some type of their bowel removed. 1/4 will have to have a splenectomy, so a spleen removed, 1/5. A minority of the patients may need a stoma formation, and almost all of them will need to have this little skin snowflake stripped. And even though we have seen that these patients will live longer, we also have the other side of the coin, which of course shows some complications from the operation, not because of a mistake of the surgeon, but just because how the patients cope, recover, and how the human tissue is healing. Yeah. So we know that these are long surgeries, they need blood transfusion, they need intensive care unit. 10% of the patients, they might need to come back again, or they might need to be reoperated. And for that reason, challenging surgery for advanced ovarian cancer can be challenging. Yeah, Susie already has, Professor Banerjee has already mentioned the BGCS. The BGCS led an ovarian cancer audit a few years ago, and now we are updating it, where we have seen that patients with advanced disease and high tumor load, many of them, namely 63% of advanced stage disease patients, will never get ever surgery as part of their journey. And does this have any detrimental effect? Yes, it does. We have seen here in an analysis that we did Imperial with another center that was not operating so advanced cases, that by adding the ingredient surgery in the whole recipe of ovarian cancer treatment, you increase and improve the survival of the patient by 60 to 70%. And within the BGCS, we did a large UK-wide study where we have seen that those centers that go for the removal of the entire disease, that go into this, how we call it, surgical effort in medical terms, these patients, this will be actually completely proportionally reflected into a better survival. And again, here you see the curve of the patients treated in centers that were doing this maximally effort surgery. So for that reason, within BGCS, within the UK community, we set guidelines. These guidelines, we presented them last year, and we set quality indicators. Surgery is not like it used to be in the past, where the surgeons would just do whatever they feel like doing, how they're trained, how their philosophy is. But we try, like our medical oncology colleagues, to have very strict quality assurance criteria, so that even though we can't really dose surgery the way we can dose a chemotherapy drug, that we still can audit and test ourselves that we are good enough for our patients. So we have tested and we have set as an optimum target for patients that need to have surgery in the UK, the target of at least 70%. And now all cancer centers in the UK need to prove that they have this indeed fulfilled. So these are the facts. The problem is that we operate women, we don't operate cancers, yeah. We don't operate a picture. So in women and the human tissue can be unpredictable. And the question is, how can we incorporate biology of the disease, how a patient recovers without technology in order to have the best outcome? So Imperial, in collaboration with the Marsden, in collaboration with other big institutions, they are now recruiting, for the good of surgery, other disciplines. AI, augmented reality, bioengineering, biotechnology, in order so that we all work together to have a complete piece of the puzzle, and have like a crystal ball to know which of our patients will do well, which of our patients won't do well, and how to optimally stratify patients. So I would like to show you some of the research that we're doing here. One of the major research activities that we do together with my colleague, Dr. Paula Crunea, is to understand the heterogeneity of the disease. What does heterogeneity means? I have talked to you about snowflakes, about sugar, about sand, and like not any of the snowflakes are the same. Every snowflake is different. The same applies to also ovarian cancer. You see here all these tiny dots on a patient's abdomen. They're different to each other. They look different, they appear different, they're just different. And we have them tested and see. We have done many analyses on the lab, how they respond to platinum, how their mutation rates are, how their immunology is, how the microbiome is. And we have seen that they don't only look differently, but they are different. And we have published that recently in one important journal in Cell Reports Medicine, and we have shown that a multi-site tumor profiling means that we don't just take one biopsy and try to determine the biology of the disease, but to really capture all the snowflakes in somebody's abdomen and try to analyze them and do biology profile of all of them, or not of just one. And what we have seen is that all these little snowflakes, they respond differently. You see here 50 patients. In every patient, every tumor has different response to platinum, so the chemotherapy drug that we like giving in ovarian cancer. Cyclin E is something that is associated with adverse outcomes. So patients with a high cyclin E usually have a bit less favorable outcome than those with low cyclin E. And we have seen that even there are patients with high and low cyclin E in their tumor sites at the same point in the same abdomen, which shows us how much still we need to learn, and that one single biopsy in ovarian cancer is absolutely not enough. Professor Banerjee talked about PARP inhibitors, and PARP inhibitors are being given for patients with BRCA mutation, but also with those with HRD positive tumors, so homologous recombinations deficiency tumors, deficient tumors, because they are those that respond most. And we have seen that even the HRD scores are different inside the same abdomen, inside the same patient, depending on what side of the abdomen you biopsy. You see here, for example, this patient, different HRD. This is the line between HRD positivity and negativity. And you see that there is approximately a third of our patients that can actually be both HRD positive and negative. And we as doctors are not really aware of it just because we didn't profile the entire abdomen. So what we do within Imperial, together with the Ovarian Cancer Action Center, is that we prospectively validate that we prospectively check whether this is the case and in what extent this is the case, and also what are the clinical implications of that. So I hope that if and when I get invited again here, I can present you the findings of this new research. So even though we have evolved a lot in ovarian cancer research, the majority of our patients will recur. So the cancer will come back, and we will see our patients coming through the door, needing more surgery, needing more chemotherapy. So we have tried to understand how ovarian cancer relapses, and we have seen that there are three ways of relapsing. It may be that the relapse, or the coming back of the disease, comes from one clone from the beginning, Then it may be that it comes from various clones that are from the beginning there, but it also can be that they come from new clones that were not there from the beginning. They're just new, or we just have not detected them. Showing again that ovarian cancer is not really one disease, but has many phases. And we as research community and clinicians community need to understand all these phases of the disease in order to be able to treat it adequately. So we have started doing 3D models. So we take tumors from surgery and we dissect them in little tumor cells. We take out the cells and we embed them in various membranes and liquids in order to create organoids. We do tumor slices, very, very thin tumor slices from every tumor to see it better and to understand it better. And we are making models that we can test how a cancer develops and resists and progresses and responds to chemotherapy in the lab, so that we are adequately prepared before we give anything new to our patients. So we have established here within Imperial a large platform of patient-derived organoids, of patient-derived explants, so that practically all this research is not being done in the patient, but in the lab before, again, we go back into clinical trials. So for the last part of my talk, I will present you another aspect of our study. I talked to you before about crystal ball. How can we have a crystal ball to predict the outcome from the onset of the disease? This is the work from Professor Rokal and Tabouage, where they have taken very conventional images, the CT images, which normally would just show a big mass here, and say, this is a big mass, it's ovarian cancer. They have gone beyond that, and they have gone the extra mile, and have developed an algorithm to segment this tumor that was there in the beginning and to create scores. And we have named that RPV score, so radiomic prognostic vector. And we have seen that the patient's survival is actually associated to this RPV score completely independently of how hard we try. It's also the biology of the disease that matters and brings needs for us to be understood in order to, at the end, have the whole piece of the puzzle. And of course, like with any score, we wanted to validate it also into external cohorts. So we have validated this in one of the biggest German centers, and we have shown exactly the same like we could see in Imperial. And we also have now validated in Vienna. And we are, as a next step, doing a large collaboration in a prospective manner. Also beyond Europe, we have gone to our collaborators in Korea, in the National Cancer Center there, in order to see whether in a prospective way, this score can be validated. It's a score that also gets explained and reflected also in the lab. Patients with an RPV high have a different morphology and different architecture of their tumors and their cells compared to the RPV low. So there is an explanation why things as they are. And I hope again that in the next years we will have much more knowledge about why some people do well and some people don't, even though we try equally hard for all of them. So keyword artificial intelligence, when we for the first time a few years ago presented this radiomics, everybody was very excited and was talking about artificial intelligence predicting chances of survival for ovarian cancer patients, which actually may not be completely true. However, there is no doubt that other aspects of our society and advances outside of medicine, outside of surgery, like artificial intelligence, like bioengineering, will actually be recruited and help us to improve, go outside of our small limits of surgery, of medicine, in order to help us best. A last example is the iKnife. The iKnife is something that was developed in Imperial by Zoltan Takats. It's called the intelligence knife. It's where all the fumes that are created during cutting into the tissue, they go into a mass spectrometry in real life, in real time, and it shows where we cut, how we cut, whether where we cut are clear margins or not, so that our patients benefit most from surgery. And of course, all cancers, they like to disseminate through vessels, through valves, through lymph nodes. We all know how lymph nodes are important in any cancer. We have tried, and in Imperial, we have characterized the first time ever, the first human valve. This is the first human valve where we have taken lymphatics from humans during surgery, affected lymph nodes that needed to be removed, and characterize them and saw how they resist to tumor cells, how the tumor cells go up and down in the human body, in order again to be able, by understanding better how all the tumor cells progress and disseminate, in order to be able to stop them. So many exciting things that are coming our way. Research is a paramount key of what we do. We have now, we're able to characterize and develop better models to mimic also in the lab the ovarian cancer disease and learn much more before we go to the human patient, to the patients. We have now better biomarkers, and I very much hope that the next steps will be to even have earlier detection of this very challenging disease. Thank you very much.